would like to introduce our speaker for tonight. He is an Archbold physician who probably doesn't need an introduction. He is a highly regarded member of our Archbold medical staff and practices at Archbold Neurosurgery Services here in Thomasville. Dr. Kadis is a board-certified neurosurgeon and has been with Archbold Medical Center for over 39 years. He received his medical degree from the University of Rochester in Rochester, New York, and went on to complete his residency in surgery and neurological surgery at Columbia Presbyterian Medical Center in New York, where he was chief resident. He is here tonight to talk about one of the newest ways to treat chronic back and leg pain. Let's please welcome Dr. Gerald Kadis.
Is this thing working? Everybody can hear me? It's clear all the way? Well, I want to thank you very much for coming out. I think this is a super thing that Archbold does. There aren't a lot of hospitals that'll give you a free supper, you know, like as nice as this, and let you have a little educational experience at the same time. And I think it's really very progressive of Archbold, and they've been doing this for years. I've done several of these. In fact, I think the last one I did was for our Gamma Knife several years ago. And, you know, in my specialty, there are things that come along infrequently that are what I would call game changers. They're things that you can really stand up and be proud about. The Gamma Knife was one, and it's still a phenomenal tool for treating non-invasively brain tumors. And we've treated over 1,500 brain tumors with our Gamma Knife unit over the years. And then there's this thing, which to me it's not as spectacular as a Gamma Knife, but for the people it helps, it is remarkable. And I'm gonna talk to you all about this. Before it's over, you'll know. I'm gonna talk for about a half hour, and then I'm gonna leave another half hour for questions, because I think the way we learn about things is through questions. And I want everyone to have a chance to ask their questions. So what we're going to do in this lecture, we're going to talk a little bit about pain and how it's treated. We're going to talk about chronic neuropathic pain, which is a particular type of pain caused from nerve injury. We're going to talk about how chronic pain is managed and what spinal cord stimulation, and more specifically HF10 therapy is. That's really what the gut business is. And then I'm going to talk to you about my personal experience in using this, just a little over a year of experience with this incredible tool is. So, and then we'll have the questions and answers. You can ask me anything you want then, okay? All right. So back and leg pain, it's a debilitating problem which people have been dealing with for years. Physicians deal with it every day. As a neurosurgeon, my office is full of patients with back and leg pain. It's a very common problem. It's debilitating. And it has led to an abuse of opiates. And we all hear about this in the news, how opiates are a big issue right now. And this device that I'm going to talk to you about is a way of treating pain without opiates. And it works remarkably well. So first thing we got to do as a clinician in dealing with back and leg pain is to first understand what's causing it. Before we treat anything, we have to make what we call a diagnosis. We like to know the cause of the back and leg pain, because from there, all the treatments will become available. But you've got to know what you're dealing with first before you treat it. We don't just dish out medication and so forth without understanding the true cause. And it can range from tumors to fractures to ruptured discs to spinal stenosis. I mean, there's 100 different things that can cause back and leg pain. Back and leg pain is a symptom. And we don't just treat symptoms. Usually we like to diagnose what's causing them and then make an intelligent decision. So that goes without saying. So, okay, so pain is the way the body interprets information about a sensation the body's experiencing. So this information is sent to the brain from the lower part of the body through the nerves, and then it goes to the brain. So the way the brain interprets this information is complex. There are many things that can affect it, It can differ among individuals who seem to have the same thing but experience something different. I see that all the time. All you have to do is go to a labor and delivery room in New York City and see how the different ethnicities respond to what should be an identical experience. And different ethnicities experience pain differently. I can tell you that from many experiences. That's another story. But anyway, people have different perceptions. Fear can come into it. Some people are more frightened, and that it magnifies the pain. Depression can magnify pain. There are a lot of things that can cause pain to become magnified. So it's a multidimensional issue. It has physical, mental, and emotional components. Okay. Chronic pain is something that persists months after the treatment is ongoing, as opposed to, say an incisional pain or a pain you have when someone cuts you. That's a pain you get right away. It goes away. But sometimes there are chronic pain issues that linger, either due to nerve injury or other factors. So, they can be an ongoing ailment, and the emotional side effects are tremendous. Pour into that a whole bunch of analgesics, opiates, muscle relaxants, and everything else, antidepressants, then you've got a whole mixture of things that can influence the perception of pain. All right. So chronic pain management, like I said, the first thing that has to happen here is you have to make the diagnosis. Can't tell you the number of times I've seen patients come in with what is felt to be just chronic pain, but there is an ongoing problem. Tumor, spinal cord compression, things that are actually happening in there that need to be dealt with first. So we first make the diagnosis, but then if we have chronic pain and the patient is functional, then you have different kinds of therapies that are out there: pharmacological, lifestyle changes, physical therapy, pain management with nerve blocks, injections, surgery, pain pumps, and then there's this subject, spinal cord stimulation. That's really what we're going to focus on today, because I'm going to tell you about something that is a signal jammer. You have seen these movies where they say, I can't get any cell phone reception. Someone's jamming the signal. Well, HF10 is a signal jammer for the nervous system. It emits something into your nervous system that literally jams the signal so the pain doesn't get through to your brain. Sounds science fiction, doesn't it? But it's in fact the real thing, and it is amazing. Okay, so roughly 8% of the population suffers from chronic neuropathic pain. Majority of this is in the low back. It costs $600 billion a year to treat this stuff. Seems amazing, doesn't it? I mean, these are big numbers. And then lots of these people are continued on chronic narcotics. And that is a downward spiral like you can't imagine. So we're talking about spinal cord stimulation next. So this is not something new. People have tried to tinker around in the nervous system since the 70s to stop pain. And the first efforts were made based on the principle that if you bang your elbow or you otherwise injure yourself and you rub it real fast and you create another stimulation, the brain doesn't feel the pain as much. And you can see this in the animal world. When you watch a dog that's been injured, they'll lick, 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 and create another stimulus so they're not feeling the pain as much. So it's a well-known fact that you can create a diverting stimulus of some sort. And this was the focus of a whole lot of spinal cord stimulation back in the 70s. And these devices worked by sending electrical pulses along the spinal cord, and then the thought was that only so many impulses could be carried to the brain. So if you sent enough impulses of some sort through there, the neuropathic unpleasant pain sensations wouldn't get through. And that's basically how it all started. And that was the Gait Theory, and it was basically, as I said, by creating a distracting paresthesia, which is another kind of sensation, then the pain sensations wouldn't go through. Well, that's kind of the way it was for many years in this whole subject of neuromodulation as we call it, in my specialty, but it's spinal cord stimulation. And there you had, for many, many years, you had all these different kind of devices. And they varied depending upon how many contacts they had, different outputs, different types of machines. And you had all these machines out there from all different companies. Boston Scientific, Medtronic, there's 100 of them out there. And they were all doing basically the same thing. They were creating paresthesia, or other types of sensations that the patient would feel as a tingle, a jolt, or something else. And that was the state of affairs for many, many years. And it wasn't a very happy state of affairs, because most people that had these devices, either they were happy or they hated it. And it was a very small percentage that really liked it. And you know, for those people it was great. But there were a lot of people that didn't want it. And a lot of my practice in terms of neuromodulation for the last 5 or 6 years was taking these devices out of people who didn't like having them. They couldn't get MRI scans because of them. And I was apparently one of the few neurosurgeons that was willing to take these devices out of people. And they were coming from all over Georgia, you know, to have their devices removed because no one wanted to remove them. But, you know, that was the state of affairs. Well, that changed. Then this HF10 therapy came out, and the way it happened for me, I was at the Congress of Neurological Surgeons meeting out in San Diego about almost 2 years ago. It'll be 2 years this October. And at one of the pain sessions, a couple of the California docs were talking about this and how great it was, and that they had just started using it in this country, that they had had trials in other countries with great success. I met with the vendor there, and I got kind of excited about it because they said it works totally differently. And the interesting thing is that it really works. It doesn't create any funny sensations. It just signal jams the brain. So, you know, after about 6 months of getting all of our approvals got set here, we started implanting them. April would be a year ago. And since then, we've put in about 70 of these devices. So that's how I got into it. And it's slowly, people are understanding about it, but it still hasn't made the news yet, big time. But it will, because it's remarkable. So anyway, the way the HF10 therapy works is it sends out a very, very high frequency signal, 10,000 kilohertz, which is something that the body doesn't even perceive. You don't even feel it when it's happening. But it is such an overwhelming signal that the brain can't feel the pain that's coming along, the neuropathic pain that's coming along. So this device was so good that the FDA, which is very difficult to please, thought this was something that was so superior to everything else that they fast-tracked it through in terms of Medicare payments and everything else, because it really was extraordinarily efficacious. Patients didn't have any of these shocking sensations or funny feelings. They just noticed that when the thing got turned on, their pain went away. That was the miracle of the whole device. So you know, you've got this high frequency signal. There are a lot of things that can be tinkered with to get it just right for each individual. The key point is that the device has to be positioned strategically at a certain spot over the thoracic spinal cord, right between T9 and T10, and we try to get it right in that sweet spot where there appears to be a cluster of nerves that, when inhibited by this signal, absolutely shut off the neuropathic pain pathways to the brain. It's that simple. So the device is put in first under local anesthesia as a trial, and I work with Dr. Shokat, pain management guy, who puts these in his office under local anesthesia, and the patient walks around with it for about a week, externalized, and sees if they like it. Well, I can tell you, of the 70-plus patients I have sent for a trial, 100%, you never get that in medicine, 100% liked it and came to my office soon thereafter, begging me to put it in as soon as I could. Well, that was telling me something there, I'll tell you what, you know. That doesn't happen with a lot of things, you know. Now, obviously, if you're dying in the ICU with a subdural hematoma, I mean, everybody's going to want to get that out right away. But this was something for pain. And pain patients can be very difficult to make happy for various reasons. But they all liked it, 100%. So what happens then is after he's done the trial, they take out the trial leads, and then under general anesthesia, we implant a permanent device that's fixed and stays there, and everything's covered up. So the whole system is internalized, and all the patient has to do is charge it up. Externally, they put a little charging device over the subcutaneous generator, and they charge it up, you know, for 10 minutes to a half hour every day. And then it just runs 24 hours a day and night. When they sleep, when they drive, it's just running in the background, and they're unaware of it. They just know that they're functioning better. So it's pretty amazing technology. And the battery's good for 10 years. The company is phenomenal. They follow every single one of these patients forever. They check with them on a regular basis to make sure they're happy. And it's not like we just put one in and forget about it. There's a continuous, ongoing customer satisfaction survey continually going. So, then of course all the publications came out, you know, and publications showed that the traditional subjects didn't do anywhere near as well as these folks. I mean, I can tell you our lines are like this because, you know, 100% liked it right off. But, you know, these were the published results that, you know, convinced the FDA, you know, that this was something unique and special when the field was littered with lots of other spinal cord stimulator devices. So the patients can be free, they can drive the car, they can run it while they're sleeping, and we can even do MRI scanning with this device in to a certain extent, the brain and certain parts of the body. We can do MRIs even with this machine in. So my personal experience at this time when I did this slide, it was 61. Now we're closer to 70. 85% recommended to other patients and would do it again themselves. 100% responded to trial. After a year, you're talking about 60 to 100% pain relief. That's pretty remarkable. So a lot of these people have come off their narcotics. That's big time stuff. If you can get off narcotics for any reason, you're going to save your life eventually, because the side effects of chronic narcotic use are incredible. So I've had 2 patients who wanted it out for their own particular reasons, but all the patients that kept the device were able to decrease their use of pain medication. So prior to, as I said, prior to doing this, my spinal cord stimulator work was explanting devices that other physicians had put in because the people were unhappy. Now we have a whole new optimism about this whole field in general. There are new areas that is being explored. Neck and arm pain is going to be another area that we might eventually be able to treat with this. Neuropathies, diabetic neuropathy, instead of treating it medically, may be able to be treated this way. And we've got patients that have had phantom limb pain, all kinds of pain issues that you might not think of, but can be treated with this. So I'm pretty enthusiastic, as you can tell. To me, this is a huge breakthrough. Instead of taking someone back for a whole new fusion or something on their spine, or putting more hardware in, or dumping more bone in, these are options that we have that really work and can be done safely, virtually as an outpatient, and it really does work. So I'm very excited about it. I think I've pretty well beaten the horse there. I really want to open it up for questions, because you know, it's your individual thoughts, because I guarantee everyone in this room either has or knows somebody with these problems, because there are a lot of people who've had everything done to them in terms of multiple spine surgeries, multiple hip surgeries. They've got scarring or something in their spine. They think there's nothing left for them. But this can be used in even people that are kind of ill. You know, we can take a person that's, you know, got other issues like renal failure, anticoagulant therapies. I mean, we can take patients that might not be suitable for a big spine operation. We can do these things. So, questions? Yeah.
Do you have one of these devices presently?
No, I don't. But it looks basically as what I showed you back here. It's nothing very special about it in terms of what it looks like. Yeah, there it is. So it looks like that. This is the guts of the thing that is implanted under your skin that you charge up. It's full of microcircuits and sort of things, but it runs the frequencies to these electrodes, or in my case, we put a paddle in that's a little bit bigger, but it sits on top of the spinal cord, and these wires go under your skin to it. So it's not a very complex looking thing, and this device here is about the size of a pocket watch, relatively small, and it's inobtrusive under your skin. It's actually less obtrusive than a pacemaker. A pacemaker, you kind of feel it, see it sticking out here, but this goes under a fatty region. You usually put it kind of in the lower back, right under the skin there. It's out of the way, above the belt line usually. Yeah.
Is it covered by Medicare?
It is. Like I say, Medicare fast-tracked this. They would much rather have someone get one of these than be on opiates the rest of their life, or on have a whole bunch more spine surgery that might not help. So, they like this device, and Medicare pays for it, and the hospital actually does okay from that too. They don't lose money on every one of these. Yeah.
How long would it have to stay in there?
As long as you like, your whole life.
They are doing the charging.
Well, we charge it every day, and the battery lasts about 10 years. But every morning you put a little charge to it, like your cell phone, and then it's good for the whole day. Yeah, yeah.
And medications cause you to have pain?
Medications cause pain. Well, if you are addicted to opiates, your perception of pain becomes increased. In other words, I see patients who... Yeah. Oh, okay. Yeah, some people will get cramps with those medications, but the interesting thing about prolonged use of opiates is these people who are on these narcotics for a long period of time, their perception of pain actually increases. So less painful stimuli cause more pain, and that's a terrible cycle that you get into with that, and it's hard to break that cycle. So the patients that we operate on that are addicted to narcotics are hard to control initially, because their incisional pain is going to feel worse to them than it would to somebody who isn't. So anyway, next question.
Why three sizes? You got three sizes.
No, it's all the same size, actually. This is the device that controls it through the skin, and then that's the device over there, and it's just it's magnified there. Yeah. 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 It's a little, well, when I was out, I met the CEO of this company not long ago out in Silicon Valley, and they are working on a generator like this, size of a quarter. That tiny. I was amazed that they could put it all in there. And he said, well, it's possible, and that may be something in the future they decide to go with. But it's remarkable what's inside that thing. That is a high power. It's like your cell phone. It's got all kinds of things. What's that?
How long does the procedure last?
Oh, to implant it permanently? It takes about an hour. It's all done as an outpatient. We do put you to sleep for it. We don't need any interaction with you when we're doing it, because it is placed anatomically. That is to say, we put the electrodes where they need to be based upon the research. We don't have to inquire, is it doing this, is it doing that, as we used to have to do with the other devices. So you get put to sleep for it, and then you go home right afterwards.
NSF, I have 3 levels of pain.
Mm-hmm.
I had it in my arm.
Yes.
Say I had it in my knee.
Yes.
Say I have it in my back.
Right. The knee and the back, this will work for. This won't get to your arm. Although, as I said earlier, there may be a device that we start using not too distant future that may target neck and arm problems. But right now, it's pretty much from here down with this device, yeah. Anybody else got a question? Yes?
Is the this particular system an option after you've tried surgery,
Oh, yes.
medication, and-
This is an option before, after, or whenever. I mean, we can do these no matter what. Now, the key point is we like to know what the pathology is that you have, so that we're not trying to give you one of these devices and you've got a tumor or something growing in your spine. Things we need to know what we have before we do it. But yes, these can be put in. You could have surgery at a later date if it became necessary. I generally put these in people who are functional. That is to say, they can ambulate and walk, but the main problem they're having is pain, and it's preventing them from doing things. Those are the candidates we really look for. Now, if people have neurological impairment, or they're becoming unable to ambulate because the muscles and they're developing neurological impairments, we like to deal with that first. In other words, if there's a cause to somebody becoming progressively paralyzed, we don't want to put one of these in them. We like to get those issues dealt with first, you see. But for the pain issue, this is remarkable. Yeah. Yes?
Does it take care of sciatic?
That's what we're talking about right here. Sciatica pain. It's the ideal pain subject, yes. Sciatica, low back pain, pain from various implants you may have had, hips, joints, knees, whatever. I mean, wherever the pain is, if it's from here down, we can generally cover it with this device. Yeah, that's what makes it so unique. Yeah.
Are you including the thoracic spine?
Well, it depends how high up. See, this device goes up at T. Yeah, between the shoulder blades is a difficult area. This device is not really designed for that. It's designed for the much more common low back pain, pain down the leg, sciatica, radiculopathy, rheumatoid, I mean, whatever you want to call those pains. It's pain from here on down, and it's chronic, and it's debilitating, and this is great for it, especially if you may have had 5, 6 surgeries these days. I see some patients who've got their whole spine fused up, bone grafts, hardware, scar tissue, whatever you want to call it. We can still put one of these devices in and help those people, and that's what's wonderful about it. Yeah.
You've been using a TENS unit for years, and
All right.
you don't seem to.
Tens. This makes, yeah. Well, if you like tens, you'll love this thing. Believe you me, because there's nothing external.
Preparation for one I discussed with someone before
Yeah.
seemed impossible to me. I was expected to not bend for a week or two.
No. You know, when the trial electrodes are in, they're not secured so securely, so they want to make sure you're not going to move something loose. But when I put in the permanent device, it's attached to your spine, so you can do any damn thing you want. You know, bungee jump, you know, for all I care. I mean, it's no problem. It's hooked in there. Take a train to break it loose, you know. Yeah. Yeah.
What about a person who has been on the opioid
Right.
for a long time?
Right.
And decides to get this device?
Try it, yes.
How does that actually work?
Well, the way it works is, yes, we'll get the device in. You know, you'll get the trial, make sure it helps you. But like I say, most people it helps. And then after we do the permanent implant, the patient and the pain management doc will work at weaning off the opioids. That's a whole process. Has to be done thoughtfully, has to be done under supervision, because you can't just cold turkey on that stuff without some ill effects if you've been on it a long time. But it can be done. You can get off all that stuff eventually, yeah.
Well, how would a person determine whether, if they're on these opioids for a long time?
Right.
And you get this device implanted, how would they determine if they're feeling less pain?
Because they have the device in as a trial, and they can walk around with it and do all the things they're doing, and they'll find out if they're having less pain and doing those things, you know. I mean, normally, you know, opioids don't block everything all the time. There are periods of the day when you're having pain, and you can see if this doesn't make a difference in your life. Yeah. Most people that are on opioids are still having pain, otherwise they wouldn't be continuing to take them, all the time. Another question, yeah?
About scoliosis.
Yes, if you're having pain from scoliosis, pain in the legs from scoliosis, yes, we put it in some scoliotic patients, sure. Yeah. Yes?
Is there an age limit?
No,
No?
no. We put it in patients that are well in their 80s, no problem. I mean, they're having pain just like anybody else. So no. In fact, it's a safe procedure for an older person because it's not a real big operation. It's not like we have blood loss to deal with or fluid shifts or all the kind of things you anticipate with a big back operation sometimes. So yeah. Yes?
So if you've had a sports injury for a long time, like on your knees or something.
Right.
And you don't want to have the surgery, knee surgery.
Right.
Or hip surgery.
Right.
Is this an alternative?
This will help with the pain,
Pain, okay.
and you can try it out and see if you like it. That's the beauty of it. You can try it out, see if it gives you more mobility, more activity. If it works, great. If it doesn't, well, that would be in the minority that doesn't, because most everybody likes it. Yeah.
Well, tied to that, with aging, arthritis seems to
Right.
be a common
Absolutely.
characteristic
Right.
of aging. Is this something?
This is what we use it for.
Okay.
These are people who have arthritic pains, where the pain is, not responding to all different things, and that's what we're using this for. Most of the people that we're putting these devices in are in the older population. They've had all sorts of problems over the years, yeah. Next question, anybody?
Being
Yeah,
diabetic
no problem.
and
Diabetic?
pain that you have,
Yes,
so it automatically go to the pain when you start hurting?
yes, sir, it does. And that's a new indication for this that we're working on is patients with diabetic neuropathy. And there are millions of people with that. Burning in the feet, unpleasant pains in the lower half of your body. You try one of these out and see what it does. You might be amazed. Yeah, might be amazed. Good questions, everybody, I tell you. Some more, anybody?
If it don't work, you can take it out?
Yeah, yeah, the trial is just put in through the skin. You can, if it doesn't do it, then we take it out. But I can tell you, 100%, that's kind of amazing. Of the 70 people we've sent for this have said it was phenomenal. What's that?
What part of the body you actually?
In your back, goes in your back. Yeah, the permanent generator sits in your side, but the actual leads, these leads here get tunneled up over the thoracic spinal cord, just below where your shoulder blades end. Yeah.
So will that affect your, say you take a shower, whatever, will that affect?
You don't know it's there. Once it's permanently implanted, you don't know it's there. It's under the skin, you don't even feel it.
So it's nothing, you just automatic do what hours?
You just do it, you don't have to think about it. All you gotta do is remember to charge it up every day. And then, yeah.
How much that thing cost?
Well, it's expensive, but the insurance companies pay for it.
So Medicare?
Medicare picks it up, yep. Yep. Anybody else? Yeah.
Is there a diminishing effect over age?
Doesn't seem to be.
Okay. So when it runs out in 10 years, you
You just change the battery
change the battery?
as an outpatient.
Okay.
Yep, that's it. Yeah.
Do you all put it in lupus patients?
Yes. It doesn't matter what illness you might have. Yes, it can be used in lupus patients. We put it in patients that are, dialysis patients, pretty sick people, and they love it. I mean, because it actually helps your medical doctor because he doesn't have to keep prescribing narcotics and all kinds of other drugs for you. That's the beauty of it. Good questions, though. Spread the word because this device is available. It's available here in Thomasville. And I know that you all know dozens of people that would benefit from it. It's just going to take a while for the word to get out there. Yeah.
It takes 1 hour for the temporary, and how long does it take if you do the permanent one?
It takes me about an hour under anesthesia. Put the permanent in, yep. Right.
When it be inside of it, you say you have to charge it up, right?
Yep.
You have, weigh anything on that side?
No, just when you're charging it, you put this little device here. It's like a paddle, and that just sits over the generator.
I have to wear
And it charges right. The generator's on the inside. You don't wear it. It's implanted in you. The only thing that you do is when you go to charge it, you put that right over it, and it sends the charge to the device. But there's nothing you're wearing.
And it takes
It's
so long.
completely out between 10 minutes and a half hour. Yeah.
So you'll have to have someone help you.
No, you can do that all by yourself. It's done so you do it all by yourself. Nobody has to help you. It gives you an independence. Well, good. Another question. Yes, sir.
Does it affect, like you go through a scanner in the airport? Or
No.
X-ray, you need to have an X-ray? Or,
Yeah, they give you a little thing that you can have
okay,
that you explains what it is. But most, pacemakers, these devices, airport people know what they are. Yeah.
and you mentioned that there is a device being developed for the neck and shoulders,
Correct.
and when is that?
Won't be long. I imagine they're working on, getting this
3, 5,
maybe less.
maybe less, okay.
Yeah. Good questions.
Is
Yeah.
there do you try to figure out, is the pain sort of, I know pain is a perception kind of thing.
It is.
But do you look for the pain person who has severe pain as opposed to nagging pain, it's,
I usually ask the patient, are you having trouble functioning because of the pain?
okay.
Are you having to take pain medication? Is it affecting your lifestyle? And then once we get past all that, we do a little workup to find out what the cause is. And if there's nothing horrendously wrong, then we can do a trial.
Can you feel it inside your body?
The device, when it's in there permanently?
Yeah.
No,
Uh-uh.
no, you don't
There's
really
no
know. It's
sensation of it being in there.
no.
Okay.
Mm-mm. Yeah.
Have you noticed the reduction in people's blood pressures?
Well, I can tell you that people are a lot happier. I mean, there's a lady here in the audience. I didn't recognize her when she came in. And she's someone we've got this device in. And it was, I hardly recognized her when she came in the door. She looked like another woman. So I'm sure blood pressure gets better. All kinds of things happen when you're pain-free, let me tell you.
Any side effects with it?
No side effect. This has got very few side effects. Very few, if any. Now, like any device, it does have the potential to get infected, during the installation. Knock on wood, we've only had one patient that's developed an infection where I had to take it out. Yeah, but, there are potential things. Yeah. Yes. Every insurance company is different, but most of them are on board with it. Yep. Yeah.
What's the estimated timeline from the time you diagnose and say it may help?
Right.
till
Get the trial. Well, that's a multifactorial question. It may depend a little bit on your insurance company. We have to get the pre-approvals these days. So, that can vary, but it shouldn't take too terribly long. We've got some patients that we've been able to get into a trial within a week or two. So, it can move fairly quickly. The ultimate implant may take, we have to get pre-approval from the insurance companies. Sometimes that's a little delayed, but most of the time they're on board, quite frankly. Yeah.
Does any type of mechanism, machinery, or anything have adverse effect on this?
Well, like I said, the magnet, the MRI machine, you can go in the MRI machine and get scanned from here up, but it's not approved yet for scans below.
Well, I know that people that have pacemakers and such as that,
Yes.
they have to stay away from microwaves. and
Right.
all that.
No, I don't think there's any problem with that. No. Mm-mm. Yeah. Any questions? More? Yeah. A lot of good questions. This is good.
Still in trial or?
No, it's out there. We put 70 of these in the last year. There are 70 people walking around South Georgia with this new device in them, and they're quite happy, yes. That's in the last year. Yeah,
I have a couple of questions.
right.
So the first one may be a little bit too technical, but do you know, because the points where the leads go are places that have been predetermined to
Be effective.
be effective?
It sits right between T9 and T10 in the midline. There's a bundle of nerve fibers right there, and that seems to be the sweet spot for its efficacy. That's been shown time and time again. That's why we place this, anatomically.
Yeah, I was wondering why T9, T10
because that's where the bundle of nerves is that seems to respond to this stimulation.
And my next question is,
Yeah.
I'm a physical therapist, so
Yes.
I'm looking at this through the lens of physical therapy. And
Good.
I have a couple of patients who have had this and come to therapy. Some have asked me about it, and I don't know
Yes.
a lot about it.
Sure.
So is this something that people may be coming to PT after? And if so, are there any
Usually,
you should know?
yeah, usually these are people that have had PT in the past.
Right.
Because, you know, we like to try everything that's non-invasive first to see if it makes them feel better. And if that works, great. You know, these are people who've had all that before, you know, but it still doesn't close any doors after. They can still go for, you know, muscle stretching, strengthening, core tightening. I mean, there's always things that therapy can be used for and after. It's not, they don't preclude one from the other.
Is there anything that we should know, any type of movement that's restricted or any
No.
timeline of things?
We've got these things bolted down inside, so whatever sort of stretching you want to do to them, you're not going to move anything around once it's put in there. Yeah. Answer the questions?
Yes, thank you.
Sure. Yeah. Yeah.
How quickly do you notice the effect?
Well, with the trial,
Yeah.
it is pretty damned immediate.
Okay.
You know, we know within a day or two that they're going to like it. And usually, there have been people that we've just put it in for a trial, and they beat a path to my office. I want it turned on permanent now, you know, quick as you can. I mean, that's the kind of demand I get usually. Yeah. Yeah.
Do you have to come my area so often for it to be rechecked by the doctor?
No. In fact, this company is quite remarkable in that regard. They have representatives that will be contacting you on a regular basis to see how your satisfaction is and what they can do to help out. So they're very proactive. Unlike most device manufacturers, once they put it in, goodbye and good luck, you know. This company, you're with them as long as you have the device. They're going to be checking on you. Yeah.
So once the 10 years have expired with that battery life?
Yes.
Do you have to go back and have that procedure done?
No. We just take, we make a little incision over the battery. We unplug the old battery, plug in the new one, pop it right back in. It's that simple. It's the same as pacemakers. You know, every battery has its own life. So 10 years down the road, you know, and that's not a very invasive procedure. All done as an outpatient. Yeah. Good. Anybody else?
Dr. Kadis,
Yeah.
when you are undergoing the trial and you decide that it is for you,
Yeah.
do you keep the thing until you implant it, or do
No.
you have to suffer?
No, you have, that's the problem. You have to come out of it. We have to go through the pre-approval with the insurance company for the permanent device. So there is a bit of a, and you know, that's unfortunate. And then even after we implant the permanent device, there's usually about a 10-day period where we don't turn it on while the wound is healing. And we take the staples out, and then we turn it on after that. Yeah.
So what's the trial period time? What's the?
A week. You get to try it for a week. See, make sure you like it, you know. I mean, that's the opportunity. You do all the things you find uncomfortable, and you try it out. But these are all great questions. Thank you very much. Hope you learned something there. All right. Good.